to enjoy it along the way. So thanks for inviting me. I'm really excited to talk to you about my favorite topic, and I look forward to the discussion today. These are my disclosures. None of them are directly relevant to what I'll discuss today. And my objectives for today are to remind you of the recently published ILAE conceptual definitions of autoimmune seizures and epilepsies to sort of frame our discussion of the sort of practical implications of seeing these patients in our clinic and on the wards. I'm going to talk a little bit about what we know about outcomes in terms of seizures after autoimmune encephalitis, and then switch a little bit to how we can identify these patients a little bit better in our clinics and on the inpatient setting as well, and talk to you briefly about the diagnostic workup. I'm not going to go into treatment here because that's a whole other talk, and I'm really going to focus on how we can identify these patients better. So we all know that seizures are very common in the context of autoimmune encephalitis. They frequently cause seizures either as a presenting feature, or the seizures can be a part of the constellation of neurologic symptoms that occur with the full-blown picture of autoimmune encephalitis. In every autoimmune encephalitis and seizure talks, you have to talk about facial brachial dystonic seizures. And the reason for that is that it's sort of a proof of concept of this idea that seizures can be the first presenting sign. So as epileptologists, we can play a really important role in identifying these patients. So facial brachial dystonic seizures, or otherwise termed as tonic seizures, are very pathognomonic. Once you see it, you never forget it. Contractions of the arm, often ipsilateral face and leg, often alternating sides, which are essentially tonic seizures. You can see with the stronger seizures here, with the prior to the EMG artifact, you'll see a diffuse electrodecrement, and these happen with LGA1 antibodies. And importantly, they can happen before the development of the cognitive and psychiatric disturbance typical of limbic encephalitis. So if you know this type of seizure, you can treat this patient early before they develop the other symptoms, and it's sort of a window of opportunity to make people better. So that's one setting in which we as epileptologists may see patients with autoimmunity. The other setting, and that's probably the setting that we're most interested in as epileptologists, is what about the clinic? So there's two settings in which we'll see autoimmune patients in the clinic. One of them is a patient who had an acute autoimmune encephalitis, was treated, left the hospital, but never stopped seizing. And on the right-hand side is an example of this. And it can be really quite tricky to treat these patients and understand their epilepsy. So on the top panel, you can see the acute MRI in a patient with MA2 antibodies, where you can see bilateral mesial temporal flare changes, worse on the right. And after follow-up, there is development of atrophy, mostly on the right, again, with associated flare changes. So it looks like this patient's developing hippocampal sclerosis. This patient was having ongoing drug-resistant seizures many years after the encephalitis, had an ictal SPECT injection as part of a pre-surgical workup, where you can see hyperperfusion in the right mesial temporal lobe, undergoes a right temporal lobectomy, and on histopathology has pretty significant inflammatory infiltrates, even though it's been years since their encephalitis. So that's one setting. And in that setting, it can be hard to know whether the autoimmune process has stopped and whether the structural injury, so the hippocampal sclerosis here, is the primary driver of the epilepsy. The other setting that we often encounter is a setting where there was no clear acute autoimmune encephalitis, but there's still an autoimmune cause of seizure. And that's probably the one that we are the most scared of missing as epileptologists. And the prime example of that is high titer GAT65 antibody-associated epilepsy. That's typically temporal lobe, bitemporal, and drug-resistant. So those two settings that I talked about, so that first slide where a patient has a full-blown syndrome of encephalitis and may have seizures as part of this, versus the second slide where the patient's primary problem is the seizures, are different. And the first thing that we did in the International League Against Epilepsy Autoimmunity Taskforce was to sort of highlight that and conceptualize it a bit more clearly, because up to then, the literature was really full of a lot of reports of autoimmune epilepsy when referring to seizures in the context of an acute autoimmune encephalitis, for example, an MDA. And to explain why that's a little bit problematic, I just want to go back to what is epilepsy. So everybody here knows this, but let's just remind ourselves that epilepsy is an enduring predisposition to generate epileptic seizures. So if you have a patient who has an MDA receptor encephalitis or facial dyskinesia, autonomic dysfunction, and in addition to that, at some point has a tonic-clonic seizure or is having subclinical seizures on EEG, that's not epilepsy. Those are acute symptomatic seizures. So let's talk a little bit about how they're different. So in the first category, in the context of an acute autoimmune encephalitis with acute symptomatic seizures, you may see different types of antibodies. They could target surface antigens like the ones listed here, or intracellular antigens. On the other hand, if you're thinking about a patient who's, walking, talking, and just has chronic epilepsy that's related to autoimmunity, typically, when antibodies are identified, they're going to be against intracellular antigens like onconeural antibodies, GAT65, not always. Or you're dealing with a patient that had an acute autoimmune encephalitis and just never stopped seizing, so has a quote unquote postencephalitic epilepsy. I'm not going to talk about Rasmussen's today. The pathophysiology is very different. So in the first, an acute symptomatic seizures from AE, the antibodies themselves can actually cause seizures. That's been shown for a couple of these antibodies in experimental models. In the second, in autoimmune-associated epilepsy, it's a little bit more complicated. And you saw this slide that I showed with a patient that develops hippocampal sclerosis and then on histopathology says inflammatory infiltrates. There can be a mixed etiology of seizures. And that's why the term associated made it in there, because it's really not purely an autoimmune problem. There's likely a competing or a mixed structural problem with an ongoing inflammatory problem. And we're not very good right now at ascertaining how much each cause or each etiology is contributing to the epilepsy, which is why we're having a hard time treating these patients and determining whether the appropriate approach is immunotherapy or treating the structural problem, for example, with epilepsy surgery, if that's a possibility. In terms of treatment, the treatment for autoimmune encephalitis and seizures is to treat the underlying problem, to give immunotherapy. And if you treat the seizures in and of themselves without treating the underlying problem, patients don't get better. In the context of autoimmune-associated epilepsy, unfortunately, patients don't respond very well to any treatment, including immunotherapy. And it's not clear whether that's because there's often a coexisting structural problem that's going to cause seizures to continue, or whether immunotherapy is just not the right kind of immunotherapy approach. And lastly, the outcome is very different. So in the context of acute symptomatic seizures, they typically remit, although not always, and I'll talk a little bit about that literature in a second, once the encephalitis is treated. Whereas in the context of autoimmune-associated epilepsy, typically the seizures continue and there's a lot of cognitive deficits that continue. And so why is it necessary to differentiate between the two? Well, it matters if you have epilepsy. There's therapeutic implications, needing to take anti-seizure meds, needing to have driving restrictions. There's a lot of implications with just having a chronic neurologic condition, but also scientifically speaking, like I talked about in terms of the pathophysiology, they're different diseases. And so we really wanted to move past lumping all seizures related to autoimmunity together because they're just different animals and they behave differently. Now, talking a little bit about autoimmune encephalitis and how patients do in the long run in terms of seizures, because these are patients that show up to our clinics a lot, and they're often asking, well, what's going to happen to me? Am I going to continue to have seizures? What can I expect? Well, there's kind of a discordant literature in that topic. In the context of surface antibody autoimmune encephalitis, so LGI1 and MDA GABA-B, there's quite a lot of variability. So one Dutch cohort that's very well cited reported that only 1% of a group of combined LGI1 and MDA and GABA-B continued to have epilepsy at long-term follow-up, whereas another cohort reported up to a third of patients were still having seizures. If you look at LGI1 itself, there's a lot of variability across studies. Probably the best study is the Mayo study that was published a year ago that showed that about a fifth of patients with LGI1 still have seizures at the 2-year mark. And at Mayo, they know how to treat patients. They treat them well, they treat them aggressively, and still that was the case. And interestingly, when they looked at their seizure semiology, they were often sort of subtle, focal aware with autonomic signs that might have been missed on prior sort of retrospective chart review type studies that had been published previously. So that may account for some of the discordance. Patients with an MDA typically do well and rarely continue to have seizures. And lastly, with GABA-B, it's sort of the opposite. Patients continue to have seizures very often, and it's sort of generally a poor prognosis condition in terms of higher mortality. It's often perineoplastic. But really, it's not just about surface antibody autoimmune encephalitis. Many patients, with other types of antibodies continue to have seizures. And if you look at overall autoimmune encephalitis, about a third of these patients are going to end up in our clinics with epilepsy. And how can we predict who's going to end up in our clinics? Well, some groups have tried to look at some predictors like EEG abnormalities. So if you have interictal epileptiform discharges acutely, or LPDs, that can be predictive of developing epilepsy down the line. If you end up getting immunotherapy in a delayed manner, so more than 6 months from the onset of illness, that can lead to worse outcomes and more seizures. And with LGI1 specifically, female sex and younger age at disease onset was associated with worse outcomes. And lastly, the antibody itself at the time of diagnosis can determine the outcome. So you can see here on the left-hand side is the outcome of people who had surface antibody-mediated encephalitis. And you can see that the majority of patients stop having seizures. So those are the green and red lines. And many patients are able to get off anti-seizure medications, and each tick here on the x-axis is 1 year. So this was a nice study because there was quite a bit of follow-up. But on the other hand, patients with intracellular antibodies, so that's anti-Hu and also GAT65, basically most of them continue seizing and all of them need to continue anti-seizure medication. So that's probably the most important prognostic indicator. So we tried to look at determinants of seizure outcomes ourselves at NYU in our database. We sort of built this database by reviewing a bunch of charts that had diagnostic code of encephalitis. The interesting part here is that if you actually look at the charts, the majority don't have encephalitis if you actually use strict diagnostic criteria. And this has since grown from 38 to about 85. And so we had a combination of antibody positive, but also seronegative patients, and we used pretty strict diagnostic criteria to determine this. And what we found was that there were a couple factors associated with postencephalitic epilepsy, some of which are listed here on a bivariate analysis, but the one that survived the multivariate analysis was the presence of mesial temporal hyperintensities on MRI upon presentation. Which you can see an example of here. And there's also basal ganglia changes in this patient who also had LGI1. So then we asked, well, why is that? Why would that be predictive of postencephalitic epilepsy? And we thought, well, maybe if there's more injury to the mesial temporal lobes initially, and maybe, having MRI changes is consistent with that, maybe that leads to more structural injury. And so, people get epilepsy because they have a more injured hippocampus. So then we looked at follow-up MRIs and we looked at volumetric changes. And we looked at whether there was more atrophy in the hippocampus and in other regions. We're interested in the perisylvian region as well, in the seizure-free versus not seizure-free group. But there was actually no difference. And I think that's actually interesting because I think what this says is that, you can have a lot of structural injury and do well. So what's different about patients who start having seizures or continue to have seizures? And, there may be another factor going on beyond structural changes. And my idea is that there's likely a proportion of patients who have an ongoing neuroinflammatory process that's driving continued epilepsy. But of course, that's more of a hypothesis, and we're sort of testing that by doing more research in neuroimaging. The other flip side to interpreting or, applying the ILAE definitions is that, when you're first meeting a patient, it's not always clear which category to put a patient in. So some patients can go undiagnosed for months or even years and then do very well. So for example, I recently saw a patient who had frequent focal aware seizures and cognitive decline for 13 months. I diagnosed her with LGI1. I treated her with steroids. She did beautifully. Initially, when we developed these conceptual definitions, there was some talk of having sort of a timeline. So if you've had seizures for 1 year, then you have epilepsy. If it's been less than 1 year, there's still acute symptomatic seizures. But if you think about that patient who's had seizures for 13 months, but was undiagnosed and then does very well once you address the underlying illness, did she really have epilepsy? No, she probably just had acute symptomatic seizures from encephalitis that went on for more than a year. And so because of that, the ILAE Taskforce essentially said, if there's evidence of an active autoimmune encephalitis, regardless of the timeline, they're acute symptomatic seizures. And the other side to that is that not every autoimmune-associated epilepsy begins with a syndrome of autoimmune encephalitis. And we'll talk a little bit about those types of patients. And it's not always clear practically which category to put them in. And ultimately, what we need now is an operational definition, because that's really what's going to guide us treating these patients, whether we can get them off anti-seizure meds and whether we need to escalate immunotherapy if the primary driving factor is active neuroinflammation. And so the primary group of patients that we struggle with identifying diagnostically is the second group, the autoimmune associated epilepsy group. So the patients that don't clearly have phenotypically an autoimmune encephalitis, but do have an autoimmune cause of seizures. And so that question's been asked by multiple groups. So how often is it that a patient who's walking, talking, happens to have chronic seizures, actually has an autoimmune problem? And the way that that's been defined has been the presence of an antineuronal antibody. And so we did a systematic review where we looked at how often patients with epilepsy have an antineuronal antibody. There was such variability in the terms of the number of the frequency reported. You can see here anywhere from 0 to 24%. And that was depending on a bunch of things, the study population that was identified, the rigor of the antibody ascertainment. If you look at the more rigorous studies, and by that I mean studies that have explicitly excluded patients with a clinical syndrome of autoimmune encephalitis, and studies in which the antibody testing was done in a rigorous manner, probably about 5% of focal epilepsy of unknown cause are antibody positive. So it's not super high, but 1 in 20 people with focal epilepsy of unknown cause have an associated antibody, that's worth looking for because it has therapeutic implications. So just to give you an example of the problem here, I'll just talk to you about a case that was presented at surgical conference. And I want you to think whether you would test this patient, whether if they showed up in your clinic or if they were presented at your institution's surgical conference, whether you would want to test this person for an autoimmune cause of seizures. So this is a 43-year-old woman. She has no epilepsy risk factors. She's had epilepsy since she was 35. She has focal aware seizures with auditory hallucinations, often evolving to receptive aphasia, and that can evolve sometimes to bilateral tonic-clonic seizures. And they're poorly controlled. She's having them about a week or so. The focal impaired aware seizures, the focal aware seizures. And the tonic-clonic seizures are every couple of months. She's non-lesional, she has bitemporal hypometabolism, she's had independent left and right temporal onsets, she has dominant greater than non-dominant temporal dysfunction, and she's had postictal psychosis before, and she has not treated depression. So I just want you to think, would you work up this patient for an autoimmune cause? And I suspect that many of us would have a different answer in our heads, and that's because, we're still not 100% certain what is the exact phenotype of the autoimmune associated epilepsy patient. But we have a little bit of data, so I'll talk to you about that. So what tools do we have to identify these patients? So most of you, or all of you, probably already know about the antibody prevalence and epilepsy score. Everybody talks about the APE score. What it's really useful for is not the patient that I just presented. It's useful for a patient with seizures who has suspected autoimmune encephalitis. So it's really more to be used on the inpatient ward, a patient who has seizures in the context of a broader neurologic syndrome. So you can see here the elements: new onset, rapidly progressive mental status changes, neuropsychiatric changes, etc. The specific features that are important for epilepsy are highlighted with the purple circle here. So new onset seizures, facial brachial dystonic semiology, and refractoriness to at least 2 anti-seizure meds. The rest is really more recapitulation of what we know about the encephalitis syndrome. And this was later revised to the APE2 score. They basically changed the weighting of some of the points in some of the items here. And this was interestingly validated in a population with cognitive dysfunction, not seizures. So if you test that in a population with a suspected autoimmune encephalitis, it performs well with high sensitivity and high specificity. There have been other attempts to be more useful in the outpatient setting in the epilepsy clinic. So this is probably the best score for this purpose. So the ACEs score, which stands for Antibodies Contributing to Epilepsy and Seizures, was developed by the Dutch cohort, by the Dutch group. And here, if you get 2 points or more, you've earned yourself an antibody panel. So that's cognitive symptoms, behavioral changes, autonomic symptoms, speech problems, comorbid systemic autoimmune diseases, and temporal MRI hyperintensities. If you get a score of 2 or more, you're still less likely you're still more likely to not have an antibody, meaning the majority of people don't end up having an antibody. But if you have a score, if you were to use this threshold of 3 or more, it would be 2's as very specific, but not sensitive enough. And so that's why the cutoff of 2 or more was used. So this was validated in a group of patients who were showing up to an epilepsy clinic, and the physicians who were treating them did not think that they had an autoimmune encephalitis clinically. I will highlight that a lot of these features are kind of reminiscent of autoimmune encephalitis. I'll also highlight that this is not very well operationalized yet, in the sense that, what I might call cognitive symptoms might not be what Dr. Bowie calls cognitive symptoms. So what exactly is the threshold? Are we talking about objective cognitive dysfunction and testing? Are we talking about subjective cognitive dysfunction that the patient is reporting? Are we talking about, treated depression that's well controlled in terms of behavioral changes, or does it have to be a treatment-resistant depression or psychotic symptoms? So there's still, some issues with the score, but at least it's a step in the right direction, and it was validated in a separate cohort and seems to perform well. So that's one option. The Oxford group also developed this score, which hasn't been as well sort of adopted because it doesn't have a catchy term, but also it wasn't separately validated in a different cohort. I just want to highlight here that they use different sort of predictors. So older age, pilomotor semiology, which is always a red flag, mood changes, limbic changes on MRI, absence of epilepsy risk factors, and normal attention scores as being predictive of an antineuronal antibody. And if you had a score of 1 or more, that was predictive. And lastly, the Stanford group developed the APE score, which is the antibody prevalence in epilepsy in surgery score. So basically, this is a score that's supposed to be used, like this patient that I just told you about in a surgical conference, to predict if you should send an antibody panel before proceeding to surgerizing someone with epilepsy. And here what they did is that they added a triad of explosive symptom onset, unusual neuropsychiatric changes, MR PET changes, focal CNS findings, refractoriness to antipsychotics. You can read the rest here. And it performs well. There was an interesting paper written by Adrian Boudram and Jorge Borneo in Epilepsy that talked a little bit about, what does the APE score add in addition to our clinical acumen? Because I suspect that the majority of us here on this call would sort of be alerted if a patient had explosive symptom onset, unusual neuropsych changes, MR PET changes, we wouldn't be going straight to a temporal lobectomy. Most of us would probably do some sort of autoimmune workup if it was with, some of the other features here. But in any case, it performs well, and it can be a nice adjunct if there's any sort of doubt. And so these scoring tools play a different role depending on the situation. So what we sort of recommended in that systematic review that we published was to first start with the APE2 score. If you have a patient that has seizures that are otherwise unexplained, they don't have a structural cause for their epilepsy, it doesn't come in the context of like developmental delay and a suspected like genetic metabolic cause. If the APE score is 4 or more, then for sure they've earned themselves a workup. They get serum CSF antibodies, malignancy workup as appropriate, and they probably have an autoimmune encephalitis. But if their APE2 score doesn't reach the threshold, but something doesn't feel right, then do the ACEs score. If it's 2 or more, then do the workup. And here we recommended doing serum for sure and consider CSF depending on the clinical situation. So what are some other characteristics that we could sort of think about in addition to those scoring tools? Well, if you have a patient with very high seizure frequency, and here I'm talking about daily to multiple daily seizures, short seizure duration, changing seizure types over time, so like a flavor that the epilepsy is sort of dynamic, early intractability to high number of anti-seizure meds, so patients who declare themselves as being drug resistant very early in their disease course. So, patients who end up having tried 4 meds and it's only been 6 months since they started seizing. And then, there's specific antibody associations that have been described. So LGA1 antibodies with facial brachydystonic seizures, of course, we talked about, but also musicogenic epilepsy with GAT65 is a very interesting syndrome. And the other thing is perisylvian semiology. So there was a nice series from Australia that talked about semiological features of perisylvian seizures, which they found in essentially all of their patients who had antineuronal antibodies in chronic epilepsy. And so these patients had sort of these multimodal auras with oral somatosensory experiences, some viscerosensitive experiences, auditory hallucinations, language disturbance, autonomic activation, and were found to be autoimmune. So that's always a red flag. And then also the autoimmune and the autonomic semiology that I talked about before. And there's some other evidence pointing towards the involvement of the perisylvian region in autoimmune encephalitis. So In LGI1, there's been a study that looked at, MEG in a patient here who had ongoing seizures, and you can see that there was posterior perisylvian dipoles. This was here a little report that I wrote up with Dr. Wenberg when I was a resident. A patient who had seronegative autoimmune encephalitis was still having seizures. Interestingly, had claustrum hyperintensities acutely when he had encephalitis, and then in the chronic phase had a MEG that showed bilateral perisylvian dipoles. And if you look at other methods, so with voxel-based morphometry, it's been shown that when patients with encephalitis get follow-up, they often have abnormalities in their perisylvian region. So this is a series of patients with voltage-gated potassium channel encephalitis. So now we would probably call this LGI1 Casper2. And it's really not just about the mesotemporal region. The perisylvian region is also involved on imaging. And why is that? Well, one possibility is that the blood-brain barrier has sort of differential breakdown in different regions. So, those target antigens are pretty ubiquitously expressed in the brain. So why would you only see epilepsy pop up in the limbic region and the perisylvian region? Well, that may be one mechanism, and that's been noted in an animal model. What's actually interesting is that there's a naturally occurring LGI1 feline model. So cats spontaneously get LGI1 encephalitis, which I find interesting. And you can see that there's greater diffusion of albumin, indicating blood-brain barrier dysfunction in the amygdala in these cats. And blood-brain barrier dysfunction has been shown in other forms of encephalitis and in postencephalitic epilepsy as well. So the general approach to workup is what I sort of mentioned before. So, once this patient has reached a phenotypic threshold, then really the cornerstone of the diagnostic workup is to do an antibody panel and consider a malignancy workup. So, when you're doing the antibody panel, for some reason the animations didn't work here, so you can't see the table underneath, but you're really testing for two types of antibodies. So I've talked about the intracellular targeted antibodies and the surface antibodies, the surface targeted antibodies. So with the intracellular target, this is really more of a T-cell mediated disease. So you can see that the antibodies are sort of like peripheral or byproducts of a primary cytotoxic T-cell process. And it's often associated with a paraneoplastic etiology, although not always. Whereas in the setting of surface antibodies, the antibodies themselves are causing disease and can cause internalization of the receptor. And, in terms of ordering the panel, I always tell trainees, and I think that's true anywhere, that the devil is in the details. And I often see patients showing up in my clinics who are worked up in another institution where, it says antibody panel negative, but when you actually look, all that was sent was a, quote, paraneoplastic panel, which didn't include any of the cell surface antibodies. Thankfully, that's becoming less and less common. But you want to make sure that when you're ordering your panel, all of the relevant antibodies, and specifically when you're looking at a patient with seizures, you want to make sure to include an MDA, LGI1, GABA B, and the Casper2. In terms of doing lumbar puncture, I feel like that's a really common question that I get asked. I generally, I was taught this in residency, if you think you should do a lumbar puncture, you probably should have done the lumbar puncture. So definitely if you think the patient has an autoimmune encephalitis, I always do it. And it's not just about finding antibodies. Yes, there are antibodies that actually have higher sensitivity in serum, like LGI1 Casper2, and there are antibodies that you will find in serum, like GAT65. But if a patient has cells or oligoclonal bands, that's also very helpful. So I generally do it. If your heart isn't really in it and you don't really want to send the antibody panel in the first place, I guess it's okay to postpone. But I think if the question comes into your mind, you should usually do it. And what I want to talk about now is, once you've sent the panel, you've tapped the patient, what then? So in a lot of the prior studies that have sort of developed these scoring tools to determine who's autoimmune and how can you predict if someone's autoimmune, the assumption is that, when you get your antibody panel back, this is your answer. If your patient has an antibody, they're autoimmune. If they don't have an antibody, they're not autoimmune. That's kind of problematic. So let's look at both aspects of this assumption. So if a patient is antibody positive, they have an autoimmune problem. Well, there's low titer Casper2 antibodies. There's glycine receptor antibodies where the assay can be problematic. Sometimes there's like an uncharacterized antigen that gets reported. So when you send it to Mayo, what to make of that? It's not so clear cut that every single antibody that's reported back is going to be definitively clinically significant. Flip side of that is, we've all had patients that we see on the inpatient side that are clearly encephalitic. So they have mesotemporal flare changes, they have an active CSF, they have rapidly progressive mental status changes, hard to control seizures. We send their panel and they come back with no antibodies. Does that mean that they don't have an autoimmune problem? No, you've already treated them with steroids, IVIG, and all the rest by the time the panel comes back. So could that be the case in an outpatient setting? Maybe. We don't really know the answer to that yet. Does the entity of seronegative autoimmune-associated epilepsy exist? I think it probably does. And I think it's really going to behoove us to try to move beyond the reliance of antibodies to sort of diagnose these patients better and identify them better and sort of broaden our view diagnostically. So just to exemplify this issue, I want to tell you about a patient that I follow that I kind of struggle with, to be honest. She's 72. She's previously very high functioning. She was a teacher, and she came with essentially new onset amnesia. She had focal impaired aware seizures that you can see here, right temporal on EEG. She didn't know that she was having seizures when she first presented. But they were happening pretty often, and she had bitemporal flare hyperintensities on MRI, which you can see here. You can notice that she already has some atrophy, but according to her family, there was nothing before this. Her TAP is very borderline, just 5 white cells, protein fine. So does she have an autoimmune limbic encephalitis causing acute symptomatic seizures? Yes. Do you need to wait for antibodies to treat her? No. So these are the Gross diagnostic criteria for autoimmune limbic encephalitis. Nowhere in there do you require antibodies to make the diagnosis. As long as you have subacute onset of working memory deficit seizures or psych symptoms, bilateral mesotemporal T2 or flare changes, CSF pleocytosis, or EEG abnormalities in the temporal lobes, and it's not something else, then you can treat the patient. Obviously, like I talked about, the issue of seronegative autoimmune-associated epilepsy is a little bit more problematic. What else do you need to do? Well, you need to make sure it's not paraneoplastic. Often the question is, well, like, how hard do you look? How often do you repeat it? If they have a paraneoplastic syndrome, I definitely repeat it. If they have an onconeural antibody, I definitely repeat it every 3 to 6 months for a year, and then every 6 months for another year. And then ancillary testing can be helpful, not necessarily for diagnosis, but to sort of give you objective markers of disease to follow. So a lot of these patients will have frequent seizures on EEG that they may not be aware of. So I sometimes use that as sort of a surrogate marker of disease. I like to repeat structural MRIs to see if there's any atrophy that's developing, and that sometimes helps me sort of color prognosis. And I do a lot of FTG PET MRIs to look for residual hypermetabolism when I'm treating someone who's had immunotherapy, is still having neurologic symptoms, and it's getting to sort of the 6 to 12 months mark, and I'm really not sure if it's worth escalating immunotherapy or not. So essentially the idea is there still an ongoing neuroinflammatory process that should be treated? And the last question that's often asked is, well, should you do a biopsy? I think brain biopsies are very rarely necessary in these patients. They should be done if you think there's something else going on. So this was a patient who was referred to me as an inpatient who was transferred from the hospital in non-convulsive status. She was confused. They had treated her with steroids, IVIG. I thought, this isn't encephalitis. There's so much flare changes. There's edema. She had gliomatosis. She's thankfully actually doing well now. I still follow her. And in fact, histopathology is only included in the diagnostic criteria of seronegative probable AE, but that's, if the MRI and CSF is normal. And to be frank, you can still treat someone even if they don't meet those strict criteria. So in conclusion, I very rarely want to do a biopsy unless I think something else is going on. Now, a very quick word about approach to treatment. Like I said, this is not the primary goal of today's talk, but your patient is hospitalized and they're sick, you never wait for the antibody panel to treat. You really just want to make sure that you're not going to hurt them with treatment. So you make sure that there's no infection. The role of antibodies is really more to sort of stratify the underlying risk of a malignancy and help prognosticate, and on an outpatient to help solidify a diagnosis. And, I tend to escalate therapy in a different sort of time scale depending on the presentation. On the outpatient setting, I like to do things sequentially to know if what I'm doing is making a difference. But if your patient is very sick, it's fine to throw the kitchen sink at them. And I generally think of 2 arms to treatment. First, you induce an immunosuppressed state, and then you maintain it. And it's very important to treat these patients quickly. So this is a paper from Europe looking at outcomes. And here the important thing is, these are patients with an MDA who did not respond to first-line immunotherapy and did not receive second-line immunotherapy like rituximab and cyclophosphamide. And you can see that there's a significant proportion of them who die and don't do well over here. So that's the darker red. This indicates the patients that are not doing well. Whereas here, those are patients who did not respond to first-line and did receive second-line. You can see those are many more that do very well. So essentially, if your patient doesn't respond, you have to escalate treatment. Similarly here, you can see that in patients with LGI1, those who were treatment later do worse cognitively. And lastly, treating these patients can be helpful diagnostically. And usually that's more so in the outpatient setting. If you're suspecting that there's something autoimmune going on, but you're not 100% sure, then it's fine to do an immunotherapy trial as long as you're very clear ahead of time and what you're going to consider a response. You don't want to end up putting patients on like chronic immunotherapy, not really knowing what's going on. But I often use this as a trial. And, if you see a significant seizure reduction or improvement in other factors like cognition, then it can support your diagnosis. And factors that I use in determining the need for long-term immunosuppression is how confident I am in the diagnosis in the first place and the type of antibody. So that's going to influence how often you're going to do periodic cancer screening, and relapses are more common in cell surface antibodies. Patients, tend to improve and then they can relapse in about 10 to 35% of cases, whereas patients with intercellular antibodies tend to have a more chronic progressive course. And lastly, any history of prior relapses are definitely going to make you want to keep someone on long-term immunosuppression and the severity of the acute presentation. And sometimes I just have the conversation with the patient. If the patient who had an MDA once, and I tell them, look, here are the rates of relapses, maybe 10 to 20%, depending on the situation. Some patients choose to go on maintenance immunosuppression for 2 years, and that's fine. Another patient might choose not to. As long as they're informed, they understand the risk benefit. I think that's okay, because we're really operating with limited data, unfortunately. So what I've talked about today is the fact that acute symptomatic seizures are very different from an autoimmune-associated epilepsy. We have some tools that can help us identify patients, and really doing antibody testing is the cornerstone of the diagnostic workup. But I want you to keep in mind that it has its limitations, and treating patients early is really important to improving outcomes, and it can be helpful as a diagnostic trial. And with that, I'll take questions. I'm going to close the door of the room that I'm doing the talk in real quick, because otherwise you're going to hear my kids in a minute. So just give me literally 5 seconds.